Good morning. My name is Hatem Ebrahim. I'm a professor of obstetrics and gynecology at Qasr Al-Aini, Faculty of Medicine, Cairo University. Today we are going to discuss abnormal uterine action and obstructed labor. I have divided this lecture into two sections. The first is the introductory section, in which I will restate some basic facts that will help you better understand this presentation. Factors that influence the course of labor include powers, which is uterine contractions and maternal effort, the passenger, which relates to the fetal position, size and presentation, and the passages, whether they are bony or soft tissue. Dystocia or abnormal labor occur if there is abnormality in any of these factors, or there is an abnormal interaction between these factors. For example, cephalopelvic disproportion is an abnormal interaction between the passage and the passenger. The two most common factors causing dystocia or abnormal labor is abnormal uterine action and cephalopelvic disproportion. Dystocia is the most common current indication for primary cesarean delivery. When you speak about uterine contractions, one has to note the work of Reynolds and co-workers in 1948, who emphasized that uterine contractions of normal labor are characterized by a gradient of myometrial activity. These forces are greatest and last longer at the fundus, considered fundal dominance, and they diminish toward the cervix. In the 1950s, Caldero Parecia and colleagues inserted small balloons into the myometrium at various levels of the uterus. They reported that, in addition to a gradient of activity, there was a time difference in the onset of contraction in the fundus, mid-zone, and the lower segment. Larks in the 1960s describes the uterine contraction stimulus as starting in one cornea, then several milliseconds later in the other. The excitation waves then join and sweep over the fundus and down the uterus. In 1959, Hendricks noted that spontaneous contractions often exert pressures approximating 60 mm mercury. Please note that the lower limit of contraction pressure required to dilate the cervix is only 15 mm mercury. In 1972, Fredman observed the course of labor in thousands of women and developed curves for it. He noted that labor is a continuous process that begins slow and becomes faster with time. The initial slow part is termed the latent phase. The latent phase for most women ends once dilation of 3 to 5 centimeters is achieved. This is followed by a faster active phase of labor from 3 centimeters to 10 centimeters dilation. This slide notes the two phases of labor, the latent and active phase of labor, as described by Fredman. Fredman accordingly identified problems with each phase in the latent, meaning the latent and active phase, and he set some cutoff values for the average length of each stage. For example, he noted that in a nulliparous patient, the latent phase is considered prolonged if it is above 20 hours, while in multiparous patients, if the latent phase is considered prolonged if it's above 14 hours. He also noted that the average second stage is about 15 minutes in nulliparous women and 20 minutes in multiparous women. Setting time for identification for these problems helped physicians to act accordingly. This slide demonstrates a partogram which helps identify fetal condition in terms of heart rate, caput and molding in the upper section, labor progress in terms of cervical dilation and head descent in the middle section, and maternal condition in terms of vital sign, contraction, strength and frequency and intravenous fluid and syntocin intake in the lower section. This partogram gives visual representation of the course of labor and hence helps us to quickly identify problems with the progress of labor and to early recognize any maternal or fetal problems, hence assisting us in early decision making in terms of augmentation and termination of labor. In 2012, the American College of Obstetrics and Gynecology developed a workshop to address the rising cesarean section rate in America. They analyzed the duration of labor in over 60,000 women with a term singleton pregnancy and a normal outcome. Following this, they modified the results noted by Friedman in the 1970s. For example, they noted that nulliparous women take longer time than expected based on Friedman curve for labor to progress. For example, from cervical dilation of 4 to 5 centimeters, this can take up to 6 hours, and progress from dilation of 5 centimeters to 6 centimeters can take over 3 hours. They also noted that 6 centimeters should be considered the start of the active phase and not 3 to 5 centimeters as previously noted by Friedman. And hence, caregivers should keep in mind that normally before 6 centimeters there is no change of dilation for many hours. Also, they noted that the median duration of the active phase from 6 centimeters to complete cervical dilation was approximately 2 hours in nulliparous women and 1.5 hours in multiparous women. They made the recommendation that when you note if a patient is making progress or not during labor, that this should not depend only on cervical dilation, but also you need to consider other factors like cervical effacement, change in fetal station, or rotation of fetal head has happened. Meaning, if a patient is not making progress in terms of cervical dilation, but is showing some fetal descent, then this is considered progress. Hence, in the presence of reassuring maternal and fetal states, the diagnosis of arrest of labor should not be made until adequate time has elapsed. The American College of Obstetrics and Gynecology hence developed new definitions for arrest of labor to prevent unnecessary cesarean section, meaning they set off new cutoff timelines for us to consider whether labor has stopped or not. For example, to say that the first stage of labor arrest has occurred in a patient with spontaneous labor, the patient should have a cervical dilation of more or equal to 6 centimeters with membrane rupture and over 4 hours of adequate contractions with no cervical change. And in the second stage, to diagnose arrest of labor or no progress, 4 or more hours has to elapse in a nulliparous woman with an epidural analgesia, or 3 or more hours in a nulliparous woman without an epidural analgesia. Compare this to the 15-minute set previously by Friedman. So basically what the American College of Obstetrics and Gynecology workshop is recommending is to leave labor to continue as long as mother's and baby condition is satisfactory. And if you cross the adjusted cutoff timelines they set, then intervention in terms of cesarean section or instrumental delivery would be necessary. It's important to differentiate between true and false labor pains. The diagnosis can be clarified by contraction frequency, intensity, and cervical dilation occurrence. If the interval between contractions shortens and the intensity is increasing, and this is associated by cervical dilation, then the patient is having true labor pains. This slide shows the parameters of uterine contractions. It has a basal tone of 5 to 20 mm mercury. It has a peak pressure of around 60 mm mercury. And for it to be considered adequate or efficient, contractions need to occur 1 in every 3 minutes, last for 45 to 60 seconds, with good relaxation in between. One of you might ask, how do we assess uterine contractions? First way we can do that is clinically, by clinical palpation of the uterus during a contraction. Second way of doing it is by means of a tocodynamometer with an external transducer which measures duration and of a contraction and interval between contractions, but not strengths of contraction. Third way of doing it is by inserting an intrauterine pressure caster, which measures strengths of uterine contractions. This slide shows the CTG, the cardiotachograph, with two external transducers attached to the mother's abdomen. The upper one monitors the duration and frequency of contraction, and the lower one monitors fetal heart rate. This slide demonstrates a normal CTG monitor recording, showing in the upper part the fetal heart rate in the green highlighted area, and in the lower section uterine contraction. As you will see here, contractions are occurring every 2 to 3 minutes, as noted by the red line spacings. As you can see in this slide, we are having contractions almost every 1.5 minutes. As you will see here, in a space of 7 minutes, as you note by the number of red lines, we had 5 contractions. By definition, this is called uterine hyperstimulation. This slide demonstrates intrauterine pressure caster used to monitor strengths of uterine contractions. This slide shows uterine contraction strengths reporting. As you can see, contraction forces are reported as Montevideo units. This concludes our introductory presentation. Thank you.